Did we lose Dr. Jett?
Nope.
Nope. And the attendees are filing in rapidly.
Thank you so much for joining us tonight for Brookline's COVID-19 vaccine virtual forum. My name is Natalia Linos, and I am the Executive Director of the FXB Center for Health and Human Rights at Harvard University. I'm a social epidemiologist working on health equity, a Brookline resident, and a Pierce mom. Tonight's program features 3 distinguished health professionals living in Brookline and working at the forefront of COVID-19 vaccine policy. The forum aims to be interactive so that you can ask the questions and receive the latest information on both the science and safety of the vaccine, and the logistics and ethical considerations in distribution plans. Each panelist will speak for approximately 10 minutes, and then we will have an hour for discussion. And over 600 people registered for this webinar, and many submitted questions in advance. While we won't be able to take any questions live, I do encourage you to type in your questions using the Q&A function on Zoom. The chat is closed, so please use the Q&A function. And before I introduce our panel, let me say a special thank you to the organizers. This forum was planned by Pat Maher, chair of the Brookline Advisory Council on Public Health, Darlene Johnson and Lynn Karsten at the Brookline Department of Public Health, with technical support from the town's IT department. And now onto our panel. Dr. Lindsay Baden is professor of medicine at Harvard Medical School and a member of the team leading the clinical trials for the Moderna vaccine. Dr. Baden is a top infectious disease specialist and will provide an update on the science behind the vaccine, including touching on issues of vaccine safety and efficacy and vaccine trial methodology. Dr. Larry Madoff is the medical director of the Bureau of Infectious Disease and Laboratory Science for the Massachusetts Department of Public Health. As a core member of the COVID-19 leadership team there, he will discuss the Commonwealth's plan for distributing the vaccine in a timely and equitable manner. And Dr. Swani Jett requires less of an introduction, as I'm sure many of you know him. Dr. Jett is the director of Brookline's Public Health Department and will outline how administration of the vaccine will occur here in Brookline. And before we begin, let me acknowledge that many across Brookline are feeling anxious about the vaccine and some are feeling frustrated around timelines. Tonight, we will try to offer answers, recognizing that the science and the rollout plans are constantly evolving. So with that, Dr. Baden, the floor is yours.
Thank you, Dr. Linos. And I guess I should acknowledge that I'm a Driscoll dad and a Brookline resident. And as Dr. Linos said, I'm a infectious diseases physician and investigator. I work at Brigham and Women's Hospital, Dana-Farber. And I do clinical research, particularly vaccine development. And to sort of set the stage on where are we with the vaccines. A year ago, maybe 13 months ago, this cryptogenic or unclear pneumonia emerged and rapidly spread around the world. January 13th, a sequence became available. And then the race was on to figure out how serious this pathogen may or may not be, and what can we do to fight it. Diagnostics were developed, therapeutics, and vaccines. And the vaccines are based on the sequence. We sort of know what the virus genetic code is, so can we then make vaccines which can stimulate the immune system so we develop an immune response? And when we think about the vaccines, I think about them in sort of 3 or 4 buckets. One bucket, which I'll come to at the end, is the mRNA, messenger RNA, which is the new kid on the block for vaccines, but the one that has emerged rapidly with a stunning data of efficacy. There are the viral vectored vaccines. We've heard about that a little bit with the AstraZeneca in the UK and the Janssen J&J vaccine with the Ad26. And there are the protein vaccines, which we've also heard data recently from Novavax and Sanofi are developing. And much of this development has been spurred and accelerated by substantial investment from the federal government, the NIH, and industry and academic collaborations. And in fact, when we look at the development of the mRNA vaccine, we really need to stop and think just a little bit about how amazing the Commonwealth is. You know, it's a company that is just down the street from us in Cambridge. And investigators like myself at our major hospitals, and much of the community, some who may be on this call who have participated in our studies. And it's been a tremendous community effort from all sides to rapidly develop these vaccines. And when we developed it over the last 6 months, that include phase 1 testing when it first goes into people, phase 2 when we understand the dose a little bit better, and phase 3 when we demonstrate efficacy. And we all heard the efficacy results, 94, 95% for the Pfizer and the Moderna vaccines right before Christmas, with then approval and now rollout under the EUA statute that allows emergency use authorization for us to deploy these vaccines given the surprisingly, stunningly high efficacy. The speed was done not by cutting corners, it was by investment. So things were done in parallel rather than series, such as the substantial investment in process development, manufacturing, scale up to make not thousands of doses for clinical studies, but tens of millions to billions of doses for local, national, and global distribution. And that was done in parallel, not in series, and that saved many years in the process. The development didn't cut any corners on safety. There were weekly safety team reviews. The Data Safety Monitoring Board, impaneled by the NIH, continually oversaw this study, the Moderna study, as well as the other studies that were under the portfolio of the government. The FDA had their VRBPAC, the FDA itself, the CDC Advisory Committee, the ACIP, academic review through peer-reviewed publication, dissemination of data to state public health departments, to the academic community. So lots of discussion, debate, a real push for transparency, although for such a complicated arena, it's hard to get all information out evenly, and it's hard to study everything. So there are many more questions than answers. But what we can say from the 2 phase 3 trials is that both the Pfizer and Moderna, which are the mRNA, messenger RNA, sort of using the cellular machinery to make the protein so that the immune system can respond, they prevent symptomatic COVID 94 to 95% of the time, with a greater effect on severe illness, such as hospitalization and death. Of course, numbers are smaller in those categories, but all the data are consistent with preventing illness and preventing significant illness. And other data that have emerged are all consistent with that. So those data are all very reassuring and have allowed us to say, how do we now use this technology to benefit the community? And I think this rolls into some of the other questions that we'll be dealing with, which is how do we go to scale? And how do we go to scale when we did not know it would work? So we may well have, come Thanksgiving, had study results return where it did not work. So we're all responding to new information that emerges very quickly, and then we have to decide how to use that information to improve health. One of the more recent events that I'm sure many of us are thinking about are the issue of viral variants. And I'm sure we'll discuss this more over the course of the hour and a half. But can the virus, which is mutating and changing, it's kind of routine, so we shouldn't look at it as a surprise, oh my, we've never seen this. Microbes, viruses, bacteria are always changing, just like we as people are always changing. They just do it a lot faster. And so this is a routine process of evolution. And the question is, does it have any implication on the immune responses from prior COVID infection or vaccine-induced immunity? And many, if not most, of the viral mutations have no impact on the immunity generated by wild type or natural infection or vaccine. But a question for all of us is, do some of them have such an implication, such as the UK variant, the South African variant, the Brazilian variant, and there are many other variants. And those are all areas of active investigation, and that will recalibrate around and use the science to guide us as to what the logical next step is in using the vaccine we have or modifying the vaccine and having a booster or a combination vaccine, kind of like we have with the influenza vaccine or the HPV vaccine or the pneumococcal vaccine. So there are vaccines that are already combination vaccines out there that we use, and that's something we have to sort out based on the science. So in the last year, we've come a long way. A lot of work has been done. Too many of us have become infected, but I think we really have countermeasures that have substantial impact on the ability of this virus to circulate and to cause disease. And we as a community have to figure out how best to deploy it. And I think that's part of what we'll be discussing. So hopefully that gives an overview of a tremendous amount of information, but sets the stage for where and how we use the vaccines.
Thank you so much, Dr. Baden. And yes, indeed. And I want to just repeat what you said, that the speed was not because of cutting corners, but because of tremendous investment and cooperation among scientists. And it is really important for people to feel that. And thank you for also touching on the variants. We had received some questions on that. So on to Dr. Madoff to talk a little bit about the plan. How do we get to scale?
Thank you, Dr. Linos and Dr. Baden, and all of you for being with us tonight. And I just want to step back for a minute and look at also the history of this this outbreak, which has been pretty stunning, really. When you think about where we were, it was just a year ago yesterday that we announced the very first case in Massachusetts of someone with COVID-19. Had not yet been called COVID-19, actually. The very first case of a coronavirus patient here in Massachusetts, to today, when we have over 500,000 people who we know who have tested positive in Massachusetts for COVID. It has been remarkable, and it is also remarkable that the safe and effective vaccines have been developed in this period of time, thanks to people like Dr. Baden and his colleagues, and some of the vaccine manufacturers actually that are based here in Massachusetts, which is also a remarkable feat. I just want to back up for 1 second and say I'm also a longtime Brookline resident, parent, member of the Brookline Medical Reserve Corps, and the Friends of Public Health here in Brookline. And it's been a pleasure to live in this community where so many people are so well informed and are also leaders in public health, and including the Commissioner of the Department of Public Health, Dr. Monica Burrell, who is also a Brookline resident. I also want to just for a minute acknowledge that the disease is very much still with us, and that we are in the midst of a second surge in COVID-19 here in Massachusetts, across the country. Even though we're, I hope, past the peak of that surge, that we're seeing fewer cases and hospitalizations than we were a week or two ago, we are still seeing more cases every day than we were, except at the very highest point of our peak in the spring, which we viewed as a pretty amazing peak. Now we're doing a lot more testing of people, so we're probably aware of more cases than we were back in the spring. We're probably capturing a higher percentage of people who test positive for the virus. I think that our ability to treat patients and manage people with COVID has improved, so that our hospitalization rate is down. Our rate of deaths is way down compared to the number of cases and the number of deaths that we saw in the spring. But this remains very real and very much with us every day. And the rate of disease right now here in our county, which is where we measure it, and even in the town, remains alarmingly high. And our most vulnerable residents still remain at high risk for hospitalization and complications of the illness. So I just want to remind everybody that it's not time to back off of all of the public health measures that we've been taking for months now. And I realize people are tired of staying inside and wearing masks and socially distancing and not being able to get together and hug and kiss their families and friends and loved ones. And it's just it is a very difficult time. I have I've never used the word heartbreaking so much as in the last year, and so many situations have just been heartbreaking to see families separated, to see people dying alone in the hospital, just the things that we have endured, to see our kids kept out of school and away from their educations is just has been tragic and difficult and heartbreaking. And yet here I am tonight telling you that we need to keep up our efforts to stop the spread of the virus. We welcome the vaccines. Here in Massachusetts, we've gotten over 600,000 doses of the two currently authorized vaccines into people, which is a reasonable number, but we have a long way to go. I am heartened actually by the fact that people are so eager to get vaccinated. And it's something that maybe we take for granted. And I hope we will see this enthusiasm and demand for vaccination continue, even as hopefully the epidemic wanes and things improve from a public health standpoint. I'm very hopeful that people will still continue to embrace and be enthusiastic, and that the demand for vaccines will still be there as the availability of vaccines ramps up. And it's so it's in some sense a good sign that that it's difficult to get the vaccine, because it means that people want it and are looking forward to getting it. And between the number of people in Massachusetts who've been exposed to the virus and probably have some immunity to it, and the numbers of people that were getting vaccinated, I think that's contributing to the downward trend that we're seeing in case numbers. And I very much hope and am optimistic that trend will continue. But it isn't a given, and it's entirely possible that there will be more surges in this outbreak before it ends. So please be patient and bear with us. People have the analogy of building the plane while flying it has probably been overused at this point, but that is kind of what it feels like from inside DPH. We have been working frantically, I would say, very hard to try to get the vaccine out to people in a way that optimizes its usefulness and also embraces principles of equity. And I'm proud of how Massachusetts has approached this. I was very pleased to be a part of, mostly as an observer, of the governor's external advisory committee on vaccination that was led by Dr. Paul Bittinger. And that committee took its charge very seriously of trying to allocate vaccines. And if you think about how do we as a society allocate things that are scarce and vital to us, even things like food, clothing, and shelter, we don't always do it in an equitable way. And it's a situation that often that just is market driven. And I think it is to our credit as a society that we have avoided that with the deployment of vaccines. And this committee, the National Academy of Sciences, Engineering, and Medicine, which first devised a system for equitable and reasonable allocation of vaccine. And then, as Dr. Baden mentioned, the Advisory Committee on Immunization Practices of the CDC, which also put out guidance on how vaccine was to be deployed. Both of those guidances were used by the Massachusetts Committee in advising the governor on how to best allocate this scarce and vital resource. And I think seeing this committee work was really something that I think would give us all pride. This committee, which was composed of some medical specialists, infectious disease experts, public health specialists, leaders in clergy and government, in really in all walks of life, attempting to come up with a system that would distribute vaccines in a way that would, in the view of the committee, save the most lives. And that was really the primary guiding force in how vaccine deployment was developed. It hasn't been perfect, and I know that many of us have experienced frustrations in trying to access the vaccine. It remains in short supply. Vaccines remain in short supply, and we again are hopeful that that will change. As Dr. Baden said, there are more vaccines that are in the pipeline and very close, we hope, to being out there and being available. And the production of both the Moderna and Pfizer vaccines is ramping up. And I'm keeping my fingers crossed that there aren't snags, because there often are snags, frankly, in vaccine production and deployment. And I'm hopeful that they won't be there, and that in coming weeks, the vaccines will be available to many more people. But it's probably not going to be available to most people until the spring, probably even late in the spring, when we're trying to get 5 or 6 million people in Massachusetts vaccinated. And as I say, thus far, we've only gotten about 600 to 800,000 doses in the state, and that includes both first and second doses. So we have a long way to go before we get to everyone. I will stop there, and I know there are a lot of questions and concerns, and I'll do my best to address them. So thank you, and I'll turn it back to you, Dr. Linos.
Thank you so much, Dr. Madoff, especially for giving us a sense of the timeline, both the positives and the challenges ahead. And you're third, Dr. Jett, because everybody wants to hear from you. When and where will Brookline residents get the vaccine? So over to you.
Well, thank you, Dr. Linos. I don't know if everybody wants to hear from me, but they want to hear something. So let me first start, we've been in a pandemic now, at least the health department, for over a year. We started quarantining people last January. So I remember it vividly. I started wearing a mask in February, and I started to travel on a plane wearing a mask. And I remember that there was only a couple of people in the airport with a mask on, and they thought something was wrong with me and wanted to check my temperature at that time of my head to see what was I thinking. And it's amazing how far we have came since then. First I want to thank all the town departments, because they have helped us, the health department. We're very lean staff. We only have 12 personnel full-time to take this yeoman's effort. My environmental department, it essentially shut down, not do operations in order to do contact tracing. And then I used Medical Reserve Corps volunteers, the school nurses, to assist us. Brookline in this area has some of the lowest numbers in this region, which is attributed to not only to the staff, but also the town administration, the select board, for listening to some of the policies that myself and ACPH had, and supported that. With that being said, we have lost 93 lives in Brookline. So, when I look at excess death, I look at these are the people that wouldn't have died up under normal circumstances. And right now, COVID is the third leading causes of death in the United States. And so if you haven't figured out by now, my practice is epidemiology. And so that's what my training is in. And, you know, we have been very fortunate in order to reduce the amount of cases in Brookline. Right now, total during this pandemic, we have 1,735 cases. We have 700 active people right now with COVID. I predicted in the pandemic that we would hit different surges. 2 weeks after Halloween, we averaged about 50 cases per week. 2 weeks after Thanksgiving, we averaged over 100 cases per week. 2 weeks after Christmas, we jumped up to 134 cases per week. And, you know, I moved to pause sports at that time and other activities that contributed to, along with the spread in the community, travel. Now we are back down, I could say, to 81 cases per week. So we are on a decline, but 81 cases per week is still at the highest that we have seen at any time before this pandemic. The highest case total per week and before this holiday season was actually April 23rd week. We had 74 cases that week. And so that just gives you a little bit of indication. So I do want to say, you know, my job is to make sure that we reduce morbidity and mortality in the community, reduce the spread of COVID, and reduce the amount of deaths overall, whether it's in a nursing home or anywhere in the community whatsoever. So even though I know there was a lot of push to open up the schools at one point and open up restaurants, but the aim is to use all the public health measures we can in order to reduce the spread of disease so that we can sort of return back to normal. So even though we do have a vaccine, we still have to wear masks. We still have to practice social distancing. And so those two are the only reasons why Brookline has been pretty much, you know, not in the red as other communities that are in the red. We are still in the yellow. Now, when I think about deaths in Brookline, most of the deaths have impacted mainly the white population and Asian. And most of the deaths have occurred, believe it or not, over the age of 75. So we had a cluster between 75 and 85, which is the highest amount. There are some outliers. We have had people that died in the 50s and 60s. Majority has happened in nursing homes, but I would tell you most nursing homes was very effective in infection control and ensuring that the spread of disease did not occur. Now, with that being said, you know, phase one, we made sure that we vaccinated all first responders and anybody that was in the phase one category. Most of the congregate care nursing homes started to receive vaccinations from ZVS and Walgreens. That will continue to happen. We also have vaccinations for specialty housing. So CVS did contact people that have fallen in that category. Now, moving forward, we're moving to phase 2, 75 plus. So the health department only receives 100 doses per week. Now, that's not a lot of doses. We do have 30 people remaining from phase 1 on our list to be vaccinated because we had a waiting list. We would take care of those individuals. The rest of our doses from this duration on would move to the 75 plus category. The reason being is that is the highest rate that we have fatalities in. And so it's to reduce that impact on the overall community. Now, we have had so far over 2,000 individuals 75 plus to sign up for vaccinations. So unfortunately, we're only receiving 100 doses per week. It's going to take us some time to get there. But there's another caveat that we might be able to reach you. So recently, Brookline Housing Authority and Council on Aging was given a pathway to be allocated doses. So we, in collaboration with them and emergency management, has decided to put forth a good effort in order to acquire these vaccines from the state, from Elder Affairs, and we plan on going to BHA sites and also senior center. So once we get those allocation of doses, hopefully we can start the program rollout of vaccines within the next 2 weeks. Now, in terms of, and these vaccines are separate from the 100 doses that we will be receiving on an ongoing basis. So the 100 doses they're receiving per week would actually start to vaccinate people in town hall 75 plus. So there's a press release that's going out to sort of explain this. Our website will be updated, brooklinecovid19.com. And then, I will open it up for any questions at this time.
Thanks so much, Dr. Jett. We have received a number of questions already. Some of them are around the vaccine safety, some around why Massachusetts is doing worse than peers in other states, especially since we have such top-notch doctors. And to you, Dr. Jett, some specific around Brookline. So let me start with Dr. Baden on the ones. One question came in and said, my understanding is that these vaccines have not been approved, but have been released under an emergency use authorization. Can you speak to that? And a second question I'll lump together is, are there any long-term symptoms that we know about from the vaccines?
So the issue of the emergency use authorization, it's a regulatory issue of how the FDA can review a new therapy quickly and not have the longer term data, 6 months, 1 year data. So the FDA, when the initial data emerged demonstrating substantial efficacy, especially against severe illness, set up guidance that would allow the emergency use authorization, and that occurred end of December. What is going on now is collecting the additional data needed for a BLA, which is a full licensure. And that is in process for both Moderna and Pfizer. They're collecting the additional information and will go back to the agency for full licensure in the near term, probably next few months. The issue of longer term safety, the safety we have is we've been using these vaccines for 6 months. So we have 6 months of safety, a little longer in some individuals, a little shorter in others. And no safety signals have clearly emerged. There are issues around the side effects where one may feel discomfort in the arm or fever or malaise for a day or two after vaccination, occurring a little more often after the second vaccination. We've all seen in the news the anaphylaxis or the allergy that's extremely rare when we give it to tens of millions of people, but incredibly important to have the safety measures in place, which is why there are certain parameters around how best to deploy the vaccine. So we have a lot of information on safety, but we still have a lot more to learn, which we'll continue to do as we scale up and roll this out.
Thanks so much. Dr. Madoff, a few people are commenting that, using different indicators, Massachusetts is not ranking very well. And how is that possible given our hospital system? And somebody did put in the question that, this isn't a public health issue. This is an operations, they use the term operations research problem. And are we using the right skill sets? And what do you think about why we are particularly towards the bottom of the ranking?
Yeah, I appreciate that. And it is something that we're working very hard at. And if you look at where vaccines have been most speedily deployed, it tends to be in areas that are lower population and rural, and frankly have had less of an emphasis on equity in the vaccine allocation. That being said, we are again working very hard to try to get it out as quickly as possible. But it is hard to reach often densely populated communities. It's especially hard to do during a pandemic and when we're trying to also keep people safe. But I would just say that we're doing the best we can to get it out there as quickly as we can. And we will continue to do so. I think we're improving both in the rate that it's being delivered, in the numerous ways in which it's being delivered, from large mass vaccination sites to retail pharmacies, which will be coming online soon, to the way that the pharmacy chains reached out to long-term care facilities and got it out quickly there. Obviously, our hospitals and healthcare facilities. We could do better, and we are working harder every day to do better. But it is a difficult problem, and it's a difficult logistical problem.
Thanks so much. And there was a similar question, maybe to you, Dr. Jett, or also to Dr. Madoff, is will Brookline be setting up locations to get vaccines in the town? We have loads of locations that could be used, and it would be easier for many people with different needs. And I'm going to tag on another question that came in advance. Somebody said, my elderly parents are homebound. Are there plans in place, either through the town or the state, for homebound Brookline residents to be able to receive the vaccinations at home? If not, what do you suggest? So more locations and those who can't go to public locations.
So thank you for the questions. Those are very important questions. First, I would say, you know, we only received 100 doses. The state did look at health equity, look at areas that was most impacted in vaccine distribution. And the state is only receiving 185,000 doses per week. There's 350,000 requests for doses. So you can see there's a overwhelming amount of ask for vaccines. Now, in terms of Brookline, our intent is to set up mass vaccination clinics once we have the vaccine. So that is our biggest barrier as of right now. We actually did a test run first for the antibody testing in May and worked with MGH. We then did 3 clinics, drive-through and also walk-up clinics for flu. And we had a EDS plan. We carried it out just in preparation to do mass vaccinations. So once we have the vaccine, we are ready to go. We have already identified places to do it. So that is not a barrier. The second part of the question is, will we reach out to people that are homebound? So right now, emergency management, we are starting to tabulate a list of everybody that might be homebound, do not make it to town home for vaccinations, or would not make it to the senior center when we have those vaccines available. And we plan on reaching out to anybody that falls in that category because we want to ensure that they can receive the vaccine. And logistics is not an issue.
Thanks so much. Back to you, Dr. Baden. How likely are people who've been fully vaccinated to potentially transmit the virus to those who haven't yet been vaccinated? And then what determines which vaccine you should get, the Pfizer, or which one should people get? Is there a difference?
I'll start with the second question first. Both the Pfizer and the Moderna are mRNA, similar construct, similar technology, similar efficacy, 94, 95%. So from my perspective, the issue is logistics. What is the easiest way to roll out the vaccine to communities? And I wouldn't think much about one or the other. There is a difference a week apart for the second dose, but again, it all comes down to logistics. The question of transmissibility, and I think Dr. Jett made the important point during his opening remarks, we don't know yet the impact of vaccination on asymptomatic infection or on carriage of SARS-CoV, of the virus in one's nose. Those studies are going on as we speak. And so we will learn more soon about the impact of vaccination on asymptomatic infection and on carriage. There is a suggestion that carriage of the virus may be decreased with vaccination, but the virus is changing and we don't have a full data set. So at this point in time, I think we all should wear masks and do the proper social distancing, and the vaccine should be layered on top of the full complement of protective maneuvers until we really stop transmission and have a little bit more information about the impact of the different interventions like vaccine on parameters such as shedding.
Thanks so much, Dr. Baden. It's not what people want to hear. They want to hear that they get vaccinated, they can go back to pre-life, but I think it's important for everybody to recognize that that is not where we are right now. So Dr. Madoff, in terms of the prioritization and who is eligible, somebody asked a question about mental illness. They said people with mental illnesses, serious mental illnesses, are increased risk of infection, serious disease, and death. Is a mental health diagnosis considered a comorbidity? And more broadly, can you speak a little bit about, some people asked, what if I'm 65 and have one comorbidity, or, like how did comorbidities maybe play in, and where do people stand on that side?
Thanks, Dr. Linos, and thanks for that question. And again, these are incredibly challenging questions, and you can imagine the difficulty. And none of this would be so hard if there were enough vaccine, right? The point is that it's going to be hard to satisfy the demand for vaccine until there is enough of it for the people who want and should get vaccinated. What Massachusetts has done and what the External Advisory Committee recommended was to use comorbidities as defined by CDC as those that are definitely associated with increased risk. And these are considered in when people with comorbidities, which is a later part of phase 2, we're just beginning phase 2 now with those 75 years of age and older. And if you look at risk factors for bad outcomes in COVID, they are very, very closely age-related, and age is an incredibly important driver of risk. The risk to a 75-year-old is many-fold higher than the risk to somebody in their 40s. And so, whereas the risk to someone with, say, immunosuppression from cancer chemotherapy is maybe a percentage higher, maybe 30, 40% higher than the accompanying group. So the age grouping is a very important way of trying to allocate on the basis of risk, and that's why it is sort of front and center in the phasing of the vaccine rollout. It's also relatively easy to establish and find people of a certain age compared to finding people with medical comorbidities. Mental health has been called out in a couple of studies looking, and the question is correct in asking that there is some association with mental illnesses and risk of COVID, and exactly what's driving that isn't entirely clear. And the risk again is there, but it's probably less than for some of the other risk factors that have been called out. For example, body mass index over 35 has a very clear association with increased risk. Immunosuppression has a very clear association. Chronic kidney disease, type 2 diabetes, those health factors have been very clearly associated with increased risk for poor outcome in COVID. That associated with mental health, less so.
That's interesting, and I'll take the moderator's privilege to jump in and say that it is interesting that we're not paying attention to mental health, because mental health might play impact on whether you wear a mask consistently, whether you do actually follow the other public health guidance, as well as being a comorbid, and knowing that people with serious mental illness are more likely to smoke. So if it was in the list, maybe they would reach the two comorbidities more quickly. And on the age point, just something that at the FXB Center, we are concerned that people of color, especially Black, Latinx, and Native Americans, are dying at younger ages. So age obviously is easy, but it does relate to inequities in a way that we wouldn't want it to relate. So I'm happy that there are other ways to deal with equity above and beyond. But any comments on that? And sorry, those were my questions.
I just wanted to add that one of the ways that one factor that we've weighed heavily is congregate living, because we've seen the effects in particularly our long-term care facilities, our nursing homes, the just agonizing outbreaks and deaths that have occurred in those facilities. And Massachusetts has been a leader in trying to vaccinate in congregate settings, not just in nursing homes, but also in our jails and prisons, in mental health facilities, in group homes, in other places where mental illness is part of the risk involved in those settings. So it's not something that we're ignoring entirely, but we are trying to get at it through some other channels. And certainly we recognize that it's a risk, and of course also recognize other vulnerable populations, including communities of color. And the vaccine group has attempted to prioritize to low-income and communities of color as well as we roll out vaccine distribution.
Thanks,
And
Dr.
I'll just add to that, you are correct that minorities have been disproportionately impacted, especially African American Latinos, but more along the lines of chronic diseases. So most of I've seen like diabetes or obesity or those factors have been more of a play into disproportionate impact that we're seeing. Even in Brookline, African Americans are disproportionately impacted 3 times more to contract COVID. And I have lost 2 friends to it. And the age range from 37 to 52. Yeah. So that's the excess death that you normally wouldn't see on the normal scale in a year, which is more of a snapshot. So we do have to begin to address that, not just in Massachusetts, but actually in those hard-hit states that, you know, people are living on top of one another in apartment buildings where we've seen large spreads of COVID. So.
Thank you, Dr. Jett, and I'm sorry for your loss. And it is that tragedy. I mean, the statistics, the difference between white Americans, I think it's 1 in 10 white Americans know a close person who have died, but it's 1 in 3 Black Americans. And that is an inequity that we should speak about. But as you know, Dr. Madoff said, there are ways to target through other ways. And I'm really glad, and maybe some of the success stories, including the fact that Massachusetts prioritized, you know, jails and other prisons. That isn't what is happening in places like Florida. So bring it back to local. Dr. Jett, one question is that the town page lists info on COVID-19 cases in Brookline. What is the difference between suspected cases and probable cases? And do they ever become actual cases?
Well, so that's a good question. Probable cases are cases that they fit all the clinical definition of having the symptoms, but they didn't get a test. Or they might have just got an antigen test and not an actual PCR test that would have identified them as a case. That's the stepping point. Early in the pandemic, I developed suspected cases, people that fit the clinical definition that called us, but they never got a test whatsoever. So I know that they were spreading. Right now, we have 700 active cases of COVID that are isolated right now. Now, I would be doing a hell of an underestimation if I thought that was all in Brookline. There are a lot of people that probably have COVID, don't know they have COVID, one, and then there are people that don't get a test. And I'm seeing that more frequently, that people might have symptoms they don't really think is COVID related, and they don't get a test. So I think, you know, one of the fallacies of this pandemic is, you know, we didn't roll out enough tests as a nation. The best way we could have did was test everybody at one time, and then the people that had COVID, isolate them, the people that was close contact, quarantine them. And, you know, we probably could have did an isolation for 30 days of everybody, shut down the country, and the pandemic probably would have been over, especially if we had stopped all travel, which to me was the key in how diseases spread. And unfortunately, I know I don't want to put anything else on Dr. Baden's plate, but they might as well prepare for the next 3 or 4 years, because there has been some epidemic or a new strand of something that I have seen every 3 to 5 years in my 25-year career.
Go ahead, Dr. Baden.
Two comments. One, the issue of what's next. I think, Dr. Jett, you're absolutely right. In the last 20 years, we'll probably have 10 new critters emerge that have caused significant trouble somewhere in the world. But I think one of the points that I think is really important to highlight, which makes SARS-CoV-2, COVID, so vexing, is the asymptomatic or pre-symptomatic state, where individuals have no symptoms, but may be amplifying virus substantially. And that was not an issue with SARS-CoV-1. And that was one of the things that I think last year, the first part of the year, slowed down the response, was trying to understand that many people may be infected and spreading the virus and not have a single symptom, which gets to the issue of testing and how to do testing to scale so we can properly help people know if they are infectious or not, and then allow that to be another parameter to decrease transmission.
Thanks, Dr. Baden. I will stay with you because we have received a few more questions. A simple one. Oh, sorry, Dr. Jett. Yeah, of course, please.
I want to ask them one quick question because the audience may want to know this information, because I've been curious, because I know, early in the pandemic, there was literature that said 40% of people that have COVID are asymptomatic and walking around. Did we actually find out the exact number that we saw? I don't know if it's in the US or worldwide, or how many asymptomatic people actually were carriers?
I don't, and Dr. Madoff may know better. I'm not aware of comprehensive data to answer that question. Many reports and many of us suspect that there are more asymptomatic or minimally symptomatic cases than symptomatic cases. So whatever number we think are the number of cases, it is probably multiples of that. But that requires large-scale sero studies, many of which are going on. But as you, Dr. Jett, will know better than I, it all depends on the timing. A sero study in Boston done today versus a sero study in Boston or Brookline done last July. What do we learn? Because there is such a temporal issue and a community issue as to which communities are properly represented systematically versus convenience. So I think there's a lot more to learn here. The principle that I can't help but want to stress is just because you have no symptoms doesn't mean you may not be amplifying virus. Wear a mask. We're wearing it for each other, for the people at work, for our families, for the schools, for our workplaces, for the restaurants, for the tea, for the bus. The less we spread, the better. And we don't know that we're infected. That's what's so problematic here, which is why I think it spread so rapidly.
I totally agree. And that's why, we were one of the first communities in the nation that actually passed the mask mandate.
Yeah, that was really important. Dr. Baden, actually, let me stay with you. Somebody asked to explain what 90 or 95% effective means. Does it mean that you might still get it, but milder? And a separate question, but I'm going to add it and make you do some mental arithmetic. How does the Moderna work on the South African variant? And does it mean, they say that there was a 6-fold decrease in effectiveness. Can you please convert 6-fold decrease to a percentage decrease?
What I'll share with you is science, particularly these large efficacy trials, answer an incredibly narrow question extremely well. So what the 2 phase 3 studies answered, 30,000, 44,000 individuals. So a large number of individuals. It prevented symptomatic, molecularly confirmed COVID infection in people who had not had it before. That's what it prevented, period. Now, there are a bunch of knock-on issues that follow those data. There were less people hospitalized, less people died. So of the breakthrough infections or vaccine failures, they were largely mild. But that is not well powered. Those were small numbers. So the impression of in thinking of the data in totality, it prevents symptomatic illness and severe illness. And if you have breakthrough infection, it's milder. But the large studies are very pointed in terms of the precision of the data. The issue of the variance and the 6-fold decrease, that report is a showing in vitro, meaning if I take some sera, some blood from somebody who's gotten the vaccine, and then I take the virus, the South African strain, the B1351, and I look at it in the test tube, it neutralizes the virus 6-fold less. That doesn't mean it doesn't neutralize it at all. It doesn't comment on T cells or other aspects of the immune system. It doesn't comment on the level of efficacy of the vaccine because it's in vitro, it's not a clinical study. The presumption is with a decrease activity of the immune response, that might have a decrease in the activity of protection, but that's not known, but that's something that is being actively studied, and vaccine modifications are already being considered so that we can stay a step ahead of the virus, taking into consideration the mutations that occur.
Thank you for all you're doing, Dr. Baden. For those of us who don't quite understand everything you
Oh.
said, we trust that you will figure it out.
I apologize.
No. It's important to recognize that it's not so clear. For what I understood is you can't tell us because there were different tests, and I understood enough, but I hope that Dr. Madoff and Dr. Jett, we're going to switch topics to something that's politically hot: schools. How will teachers receive the vaccines? Are there any plans for the town or the state to administer the vaccine in schools for teachers? And, are they, when will this happen? And what about music teachers or teachers that might be sort of not in a system like our public schools?
So that's a good question. I'm starting to receive a lot of questions surrounding that. And I don't know if Dr. Madoff can provide more insight, but what I would say is I have asked the school superintendent, or at least his administration, to talk with DESA to find out if that's an avenue where they can get vaccinated or receive the vaccines. We would collaborate with them. We have already vaccinated all of the nurses in the school in preparation to do mass vaccination in the school system. And we will operate it the same as we have with BHA, Brookline Housing Authority. So we would ask them to put in an application or submit it to the state, put us down as a partner, and then open up that gateway of vaccinations. When that will occur, I'm really not sure. So I would turn it over to Dr. Madoff to respond.
Sure. So teachers, particularly early education and K through 12 teachers, were prioritized by the advisory committee and also by some of the national bodies that looked at this. And they are considered, along with other essential workers, as part of phase 2. So the next phase, so ahead of the general population, and would probably, I think we'll start seeing vaccination in that group if vaccine rollout goes according to plan and supplies continue as expected, probably sometime in the next month or two. And so, we're looking, I think, at March, probably late March, early April, for vaccination of teachers. And exactly how they will be vaccinated is something that we haven't completely sorted out, because it is still something that's in the future. And as I say, we're still building the plane. But I think in all phases, our expectation is that people are going to have multiple channels to get vaccinated through, whether that's at a mass vaccination site, whether that is through a local board of health, through the town, or through the school itself being able to offer vaccines. That's not. I'm hopeful that all of those retail pharmacies and other systems will be available for people, including their providers and their healthcare systems. Also will have vaccine available. And the idea isn't that there's going to be one particular system for a particular phase of vaccine rollout, but that many systems will be available and will be made available to whoever is eligible in that phase.
That's actually a great point. And I want to piggyback on, so Dr. Jett said that he is receiving 100 vaccines a week, but if you're 75 plus and live in Brookline, there are other ways to sign up in other areas, right? And do you want to speak a little bit to what, there was somebody about the timeline for 75 plus, what they should be doing today?
Sure. So we are, again, working feverishly at improving the rollout to seniors, to 75 plus folks. We have upgraded, improved, I hope, the website, which is mass.gov/COVID-19 vaccine. And you can look there, you can see a map of where it's available. So it is already available at several of the mass vaccination sites, including Gillette Stadium and Fenway Park, and a hotel site in Danvers, and a couple of sites in Western Mass. And those numbers are increasing daily. So the numbers of of vaccinations available at each of those sites is increasing. We are also, as I mentioned, deploying to retail pharmacies now. So the deployment to retail pharmacies that initially went to long-term care facilities is now being rolled out to the pharmacies in the community, and also to hospitals who will work through actually, the Mass Medical Society is working to develop a depot system where hospitals will be able to deploy sort of smaller amounts of vaccine to practices and to other sites. So it's not all on the town of Brookline, and I know that 100 doses is a very small amount compared to the demand. There will be other avenues through which the vaccine is available.
Thank you so much. Dr. Baden, we got a question from people who are of reproductive age. Is there information on embryo fetal development and male sterility safety? And they said, I understand this is a key part of drug development, especially in treating women of childbearing potential. Is there a safety risk treating younger people with this vaccine in the absence of safety data?
I'm not aware of any data of reproductive risk. And the preclinical models have the usual models that the FDA requires have been done and show no evidence of risk. And the mechanism of action of the mRNA is it just gets into the cytoplasm, doesn't get into the nucleus. It's all local in the arm and the regional lymph node. So there's a priori reasons why it shouldn't be a problem. The preclinicals shows no evidence of a problem. And thus far in the clinical rollout, we see no evidence of a problem.
Thanks. And there was a separate question on mRNA vaccines. And, there's a lot of misinformation around what that means, fragments going into our DNA and the Pfizer vaccine entering the cytoplasm and cancer developing. What can you say about this fear that we haven't really done mRNA before? Is that correct?
Well, we haven't had an approved vaccine for an infectious disease. The vaccines, the mRNA technology has been used for many years in development for a variety of vaccines, including for infections, but only in the last year, given the urgency to the scale that we've seen, to approval. But the mRNA is very transient, it's short-lived, it's only in the body for hours to days. It does not get into the nucleus. It doesn't interact with my DNA, with the host DNA. It's all peripheral in that sense and cleared. And if we think about it, my mouth is covered in bugs. My stool is covered in bugs. My intestine is covered in bugs. My skin is covered in bugs. My nose is covered in bugs. We are interacting with bugs and bug DNA and bug RNA every time we brush our teeth. And so we're now giving it in a different format to harness the immune system, but it shouldn't be a surprise to us that our immune system is interacting with microbial or bug DNA and RNA every day, all the time.
Thanks for that wonderful imagery, right? Dr. Jett,
Yeah.
go ahead.
I was going to say, I need to go get in some Clorox and scrub it down. So, I noticed people in the audience that, I think recently I did, I don't know if I did a video, but I actually recorded a video by Big of me taking the vaccine with the police chief and the fire chief. And it was surrounding the thought or the premise that many African Americans or minorities are very apprehensive on taking the vaccine. And so, Dr. Baden, I want you to address that, but also the fact that, there's a lot of YouTube video, people discussing like African Americans have lower protein in a body, and, by injecting them with this type of immune response to a heightened protein could have some different effects that people are not aware of. And so if you could talk a little bit logistically about that, that would be helpful.
Dr. Jett, thank you so much for raising that. Just in thinking about what in the last year has been some of the more frustrating elements. When does a face mask become a political issue versus a health issue? When does disinformation or the infection of quality information with disinformation. So we just confuse each other. And the internet, which is terrific for sharing information, allows so much disinformation to confuse us. And that's just so frustrating. And the vaccine hesitancy that Dr. Madoff, you talked about earlier, I think is something we cannot underestimate. Right now, we're in the situation of a shortage, so people are anxious to get the vaccine. But I'm deeply worried about once we get through the people who want to be vaccinated, if we don't vaccinate all of us, I hope we have learned that infectious diseases like a respiratory virus, we're all at risk if we all don't take care of each other. And we need to think about how to do that. And it doesn't affect the proteins, and it's not different in you, Dr. Jett, or myself, because you're Black and I'm white. I got the vaccine. I wouldn't hesitate to recommend others to get the vaccine because it really works. And there isn't a difference in how it works in me or you. The difference is whether or not you come to get it, because you get confused by the disinformation. And that has been an incredibly frustrating element, at least for me, in the last year.
Yeah, I totally agree. The disinformation is a dish to science. So definitely a dish to science.
But can I just add, again, taking off my moderator hat, I think it is important to recognize that science has failed communities of color, especially African-American communities historically, and we do have a racist system. Public health is still, we're still struggling with that. So acknowledging that there might be more fear, there might be more hesitancy, but it's important to also say that our bodies, race is not a biological construct, it's a social construct. So there's nothing biologically different for how the vaccine should work, but to know that some people might be a little bit more reluctant, and to make sure that we're ensuring access in those places so that you're not doubling, the challenge. Not only are people a little reluctant, plus they have to travel really far, plus they don't have access to a car, so they can't do the car through. So there are ways, and maybe I'll put that on Dr. Madoff, who spoke about equity quite a bit. And for anyone who wants to jump in, somebody did put in the chat a question: what would you say to my brother who is hesitant to take the vaccine? How can I talk to him to reduce this fear and suspicion? So real words, give us some words to speak to people.
We know from the history of vaccines and from working with people with vaccines that the strongest message to give people about vaccines is from their provider, from their doctor or healthcare provider, telling them that they would get the vaccine, that they would recommend it to their families, and that their families would get it. I think that has been a strong part of what we're trying to message and asking healthcare providers everywhere. And it's part of the problem with the system when we have mass vaccination clinics and people are going to, sort of anonymous locations to get vaccinated, that it doesn't always come with that strong provider recommendation that we know is so important in getting people to have confidence in vaccines. The DPH and other parts of the state are working very hard on communications about the vaccine, about its safety and efficacy. I think, we have been and will be completely transparent about the risks and benefits of the vaccine. I agree with Dr. Baden. It's really important that we get it out to a large number of people, and that after this enthusiasm in the first wave goes away and there is adequate supply of vaccine, that we're still going to have to keep working. And as with all equity issues, we have to work harder in those communities where it is less accepted and where there is hesitancy, and we really have to step up our game in those areas and reach out with messaging that's culturally sensitive and appropriate, and acknowledges the history of racism in healthcare.
And I would just add to that, Dr. Madoff is right. There were studies that showed that people were more accepting of taking it from their provider, but it depends on where you're at in the country, and it depends on the influence of the health department. What I've noticed in my career, and I've worked in different systems, when you have a county health department, most of the time vaccinations occurred at the health department. I remember going as a young kid in Chicago, and it wasn't to my physician, it was to a health department. A lot of physicians won't even carry the basic vaccines because it's not cost prohibitive for them to do so. And that still is the case today. And so what brings in acceptance is usually, if it's a minority, it's somebody that looks like them, that has a good public health message, that provides credence to the populace, that they understand and the person can articulate, and they trust that person. Because it's about building trust. I've had many people, and the reason I posed the question, Dr. Baden, is because I've had more people reach out to me in the pandemic about the vaccine, about which vaccine to take. And also just to walk them through, if they had COVID, how to help them mitigate the circumstance and how to stay healthy. And that's because they believed in what I did as a public health official. And they believed in the message, and they believed in, I practice this. Because the key is, does your physician practice this? Does your public health person practice this? I try to work out, live healthy, eat healthy, but also I believe in masks from the beginning. The reason I believe that asymptomatic people need to wear masks is, guess what? I went to Africa and I had to deal with Ebola. I didn't have Ebola, but I knew in order to protect myself from contracting it, I needed to wear a mask. And so, number one, if we're going to be in a pandemic for a while, I don't think masks will ever go away. But I think the more that people take the vaccine, have acceptance of the vaccine, do not listen to the vaccine distractors, the faster that we could return to a new normal, because we would never be what the old normal was. It'll be a new normal. I think in the future, we will always fly with a mask on. I don't see that as something that'll go away in the future. So that's just my thought on it.
That's actually, somebody did have a question about when will COVID be eradicated? Will it be eradicated? And how and when will it happen? And Dr. Jett made his prediction that at least some practices. Dr. Baden or Dr. Madoff, do you want to jump in on that sort of bigger picture?
We've had coronaviruses circulate amongst us for many, many years. So I don't think we're going to get rid of it. The question is, can we reduce the morbidity so that it becomes a cold versus a serious illness? And might some of the countermeasures we're developing help us get there a little bit faster?
I would agree with that. I think that we're unlikely to completely eradicate. We've only ever eradicated one human disease, smallpox. And so I think it's, and as Dr. Baden said, we know there are coronaviruses that are with us. In fact, there's interesting history that one of the so-called, endemic or community coronaviruses that's with us may have originated in a similar kind of an outbreak back in the 1800s.
Okay, so now members of the audience want very specific, concrete advice. I think they appreciate that they have options, but somebody asks, it's concretely, what do you recommend? Do I wait for the Brookline Department of Public Health to contact me? Do I wait to be contacted by my doctor, or do I go to mass.gov and duke it out? And what should they do? And I think obviously it depends, but can people speak to what advice? And there was somebody else saying, if they don't want to sit in front of a computer over and over, will there be other ways? And I think it's Dr. Jett and Dr. Madoff, but Dr. Baden, feel free to jump in.
Well, I'll let Dr. Madoff speak first because he has definitely more information than I do.
Yes, and I know one of the questions that compared it to trying to get Beyonce tickets, and I've seen that in the news. Being online, and how good is your bandwidth, and how many devices can you use at the same time? It's unfortunate that it's become like that. As I say, we have improved the website. I think that most people who are part of a healthcare system will be reached out to by their provider in time, but they may need to be patient. And I think that if you're eager to get the vaccine now, I think that going online and trying to find an appointment right now is the best option. The state is looking at deploying a phone-in system a telephone-based system, and I'm hoping that that will come out soon and will be an option for people who are less fluent in laptops or iPads.
I would just add, make one appointment, because if you make 2 appointments, you're taking up a slot for somebody else. If you fit into phase 1 or phase 2, and if it opens up, go to wherever you can to get a flu shot. We get the flu shot too, but get a COVID shot. So if you got to go to Gillette, go to Gillette. If you got to go to Reggie Lewis Center, go to Reggie Lewis Center. If you can make an appointment at CVS or Walgreens, please do that. I can't say when public health or Brookline will actually get enough vaccines to have a mass vaccination clinic, but by any means, if you can figure out a way in order to get a vaccination, go for it.
But ultimately, the real solution to this is at the federal level and increasing supply. And how do we as a society value enabling supply for these kinds of things? Because that really is the way to solve this.
Yeah, and I would just add, I do know in the news, President Biden has agreed with Pfizer and Moderna for 200 million doses. So they are releasing the doses that they were holding in a stockpile for the second dose. So maybe states will get vaccines a little bit faster and getting people on them. Because that's the key, because it's predicted that everybody that wants a vaccination would be able to get one through the summer, and we'll be out of the pandemic by the fall. Now, to me, if that's true, and Dr. Manoff and Dr. Beatty can correct me, that would mean we have vaccinated 250 million people, or plus, with that combined with people with COVID, because that'll give us 70% of the population, which would provide herd immunity. But maybe Dr. Manoff might have a different number.
I would just say we don't know the number, honestly, Dr. Jett. I think we are continuing to learn about this virus, and predictions are very hard to make. I think when 70% was an estimate of the population that would need to be immune based on some earlier understanding of the transmissibility of the virus. And I think as the virus apparently has increased in transmissibility, as perhaps immune variants that can evade some of our immunity come out, I think that we may have to get higher levels even to see completely to see the transmission tamped down.
But I think two additional parts of that equation is, as we get past all of those of us who want to be vaccinated, there will be large swaths of our community that are resistant for all sorts of reasons, and that we've already spoken about, but that will take a continued effort of education. And then the other piece is, if there were to be a slowdown in transmission over the summer, because there may be some seasonality of transmission based on some biologic and sociologic factors, we shouldn't lose that time in terms of getting people vaccinated. And I worry that as the rate of infections fall, people may think, I no longer need this. And we lose the opportunity to get our community immunity to where we need it to be.
Yeah, I agree. And I would just add, I think this would be a seasonal vaccination, just like the flu. Maybe, Dr. Beatty, you can respond to that. So I don't think it'll be a one and done. I think we'll probably be doing this for a few years.
I know as much as you do about that. We shall see as the seasons come and go.
But on that point, Dr. Baden, on herd immunity, but also on children, we haven't spoken about children yet. Can you speak a little bit about what the vaccine trials in children are looking like, what the timeline will be, and what does it mean to not have vaccinated children for herd immunity?
So the issue of, can children get infected? Yes. Do they seem to get infected with a little less vigor, or maybe a little less virus? That also seems to be the case. But there still is value in vaccinating children, because they're very good, as I'm sure with your Pierce child and my Driscoll children, there's a lot of sharing of more than just space. And the issue of how do we know the vaccine is safe and effective in children? And first, we understand it in adults, which we do. And now the studies of age de-escalating, both by Pfizer and Moderna, are well underway, some of which have been completed. So we'll have those data soon, but you don't age de-escalate from 17 years to 17 days. To 12 years of age to 6 years of age, you work your way down. So those are being done rapidly, but those data aren't yet available, but should be soon. And likely that will become part of how we think about getting that herd immunity to where we need it.
And pregnant women, should they vaccinate?
The current recommendation, we've discussed this a little bit earlier, but there are some other pieces that I omitted. The ACOG, the American College of Obstetric Gynecology, some of the bodies that think a lot about pregnancy and how to enhance safety do recommend vaccinating. The issue of COVID infection is probably worse. And so one has to think about the unknowns and try to balance it. But there are recommendations by different bodies that recommend it, but all of these choices are always an individual choice.
Great. Dr. Madoff, one last question to you is about professions and eligibility. Somebody said, my 90-plus-year-old parents have independent home health aides. Are they eligible to receive the vaccine in phase 2? And if so, what type of proof do they need to provide to demonstrate eligibility? And somebody had emailed in, they're a librarian. Like, do they count as educators? Like, how do we, for people who don't fall clearly into one of the categories, is there an eligibility checklist? How do people work through that?
Well, right, that's a very good question. And of course, as we keep saying, this is all of these questions are really driven by the scarcity, and I'm hopeful and optimistic that there will be less scarcity going forward, that there will be more vaccine available to more people, and these questions will become a little bit less, urgent. But there's no vaccine police, right? Nobody is going to be out there saying, you're eligible and you're not. A lot of these decisions are going to be made, at the vaccination site. People are going to say, are going to see whether someone is eligible. There's very good guidance available on the website of the state. It really does list very specifically for phase 1 and phase 2 critical infrastructure workers who exactly is included in those groups. And the department has spent a lot of time sort of going through and determining categories of eligibility. So I would urge people to look there. A lot of those questions are answered. I would mention that home health aides actually, or home health workers were actually are prioritized in phase 1 actually, and are all currently eligible. And they're usually there's they can get a letter from their employer or other mechanisms that they can become eligible, but they are already eligible and should be getting vaccinated. However they can, either through their employer, through a hospital system, or at one of the large vaccination sites or retail pharmacies. But home health workers are healthcare workers and should be vaccinated now.
And I would just add, Brookline Public Health and Emergency Management, we did vaccinate home health aides that work with the Senior Center.
Great, thank you, Dr. Jett. And one last difficult question for you, Dr. Jett. I'm a 60-year-old tenant in a large apartment building. Many people are older. Why are people in low-income housing with younger people going to be vaccinated before us?
So I would have to know which facility the person is, but I do know that we are working with Brookline Housing, age restricted, to make sure that we vaccinate that group. So I do know that we're working on it, and so it's an ongoing process. So anybody we have identified that is in senior living or age restricted, Brookline Housing or other entities, we're reaching out to them now.
Thanks so much, Dr. Jett.
Okay.
So we are 5 minutes from the end of this really fascinating discussion. We jumped around a lot of topics. We didn't get through all the questions, but many of them. And I want to make a point that, I joked that sometimes this is really serious and it's really difficult. And I want to thank the panelists, not only for joining us tonight, but for the work that you do every day. I know that all three of you are working overtime. And so it's difficult, and it's difficult to be responsive to critique as well as praise. So the praise tonight is thank you for being here with us to answer questions to your best of your ability and to continue being available to us. And I will let you each say a word, a closing, 1 minute, what you would like to leave with the Brookline audience tonight. Dr. Baden, we go in the same order. You can start.
It's been an incredible year. We are all in this together. I hope we all realize this virus doesn't care. It will spread and we're in this together. I hope will bring our community together in how we respond to repel the virus. All the things we've talked about for the last hour and a half are different sides of what we can each do individually and together to be as thoughtful as possible in stopping spread and hopefully taking care of each other a little bit more.
Thank you so much. Dr. Madoff.
It's been a hard year for all of us in many ways, and we are fortunate to see some light at the end of the tunnel now, in faster than I frankly ever would have expected in terms of the availability of vaccines. It makes me feel hopeful for the first time during this whole pandemic. It's really been the advent and seeing vaccines really get into hundreds of thousands of people here in the state is making me feel a little bit of optimism for the first time. I will remind everyone again that there's a lot of hard work, and it's really hard in this after enduring all of this for a year to keep up our vigilance. And finally, I just want to thank you all, obviously, by being here. You're showing your interest and concern about the pandemic and about public health. And thanks for inviting me to join you tonight.
Thank you. Dr. Jett, you get the closing word and any reflections.
So first, I want to thank everybody for joining us today. My last word would be I want everybody to stay vigilant. And that's being villainous and vigilant at the same time during the pandemic. It is not easy. The numbers that Brookline Town present and put on our website, they are people. And so, even during Brookline, they're I would say in their senior years. In other communities, it is not the same. If you look to the left or the right, there are young people dying. And I think we need to continue to, take this very serious, because for every one person that contracts the disease and dies, the statistics show it impacts at least 10 people. And so it takes a lot of hard work. A lot of people want to continue to live life as usual. Life is not normal in a pandemic. And so my heart goes out to the families that have lost, loved ones, that continue to deal with unemployment, that cannot, the students are falling behind due to a variety of reasons, and there's mental health concerns. There's no right answers here. Everybody's here is trying to save somebody's life, trying to reduce the amount of transmission overall in the community, and trying to reduce death. And so, with that being said, we give special thanks to everybody in the town that has helped us and everybody that collaborated to put this forum on tonight. And I wish everybody well and good luck and good night.
Thank you so much. And this is just a slide with information for any follow-up you might need. And everybody have a good night.
Are
Okay.
people still on?
So this is Lynn. I just want to
Looks like
applaud. I
we're
want us
still
to
Live.
all
We are still
thank.
live on YouTube. Do you want to stop the YouTube live screen?
Yes. I just wanted to thank Natalia on behalf of all of us. We gave her a thankless task, which she handled beautifully. We threw questions at her while she was figuring out the previous questions and organizing them into nice categories. And you just did an amazing job, Natalia. The speakers were terrific, but I just had to give a shout out to Natalia because that was